Well, thank you all, and thank you, John and Leanna, for including me today. When I used to work for a congressman from Texas back in the 1980s, and the thing, one of the funniest things that you could say, the big joke in Texas was, I'm from Washington and I'm here to help. And today, we have quite the opposite, because for those of you who haven't figured this out, we have a serious problem in Washington right now. And, you might ask, which problem? Which is a fair question. But since the topic of this is healthcare today, we have a serious problem in healthcare. And I wanted to start by mentioning that in 2013, a number of organizations, one that John led, a number of groups came together to try to come up with ways to lower cost and improve quality in our healthcare system without shifting cost to consumers, to businesses, to providers, figure out a way to move into a value-based system. And there were a lot of other really tough provisions in some of those. One adjusted the cap and deductibility of health insurance coverage. Another really went after graduate medical education and tried to make it look more value-based. And then, of course, there were proposals to really limit reimbursement for prescription drugs, particularly for oncologists. And when we took those proposals up to the Hill, basically the universal response we got was, well, that's all really nice, but we're not doing that because it's too controversial and they just don't have the will to do it. And over the last 6 months, we have done some really scary things in Washington. We have added trillions or billions, I always mess those up, I'm a lawyer, trillions. We have added trillions to the federal deficit. And I almost liken it to Congress being on, I don't know whether it's 6-year or 6-month toot. And once they wake up and realize what they've done, suddenly they're going to be, once they sober up, they're going to suddenly decide, oh, the deficit is a huge problem. Where do we go? The healthcare system. And the first things that they try to do is cost shift to individuals, cost shift to providers, cost shift to businesses, without making any of the tough decisions that will be discussed here today that really think about paying for value and being a little more concerted about that. So let me tell you a little bit, first of all, about the BPC. It was founded 10 years ago by 4 former Senate majority leaders to try to start a dialogue in Washington. They were concerned that over time, Congress was becoming more and more polarized. And so they wanted to come together and create an environment where folks could sit down, talk about their differences, and come out with reasonable compromises. So one thing that, and in addition to doing healthcare, BPC has about 20 other initiatives, ranging from economic policy to national security to early childhood education. So this is just a small component of the work we're doing at BPC. And one thing that sets us apart, I think, from a lot of the think tanks downtown is that we have a sister 501c4 lobbying arm, which means that we have people whose job it is at BPC Action, which is the name of the organization, whose job it is to go to the Hill and talk to folks and find out what is of concern to them, what is coming up, what they think we should be focusing on. But at the same time, when we come up with proposals, they go up to the Hill and talk to them. So there is a definite engagement with policymakers as we go forward. So the 2 leaders of the Health Project are former Senate Majority Leaders Tom Daschle and Bill Frist, 2 leaders whom for those of you who know them, have a very strong commitment to health care. So I'd like to talk about some of the recent work that we've been doing. We put together, as I mentioned, a number of groups put together policies in 2013. And one area where we found there was the most agreement was in moving in the direction of value-based care. And the reason I say I'm from Washington and I need your help is because I think we finally reached the conclusion in D.C. that the answers are not in D.C. The answers are out in the states. And there's no single one-size-fits-all solution. Now, it's taken me 30 years in health policy to figure this out, but when you live inside the Beltway, sometimes you're a little slow. But one of the things that we have been working on, in addition, first of all, I should say that we also have a major initiative that is working on health insurance coverage. It's known as the Future of Healthcare, that is co-chaired by former Senate Majority Leaders Daschle and Frist and former CMS Administrator Andy Slavitt and Gail Walensky, who was the CMS Administrator back when it was called HCFA. And we've also done some work in the Children's Health Insurance Program and also have a prevention initiative. And the reason I'm saying this is because at the end of presentations, I always get questions. Why aren't you focusing on prevention? Why aren't you focusing on this and that and other things that are more important than what you're doing right here? And I'm just nerdy enough to think this is probably one of the most important things. But I wanted to mention that there are other initiatives going on there. So what have we been trying to do in the last 4 years? I think there's been an agreement that what we really need to look at are those who are driving costs in our healthcare system. And we've all seen the data. It's those with multiple chronic conditions. And we hear and have heard for 20 years about these sites around the country that have been successful in controlling costs, bringing down costs for these populations. The challenge has been that we are consistently told that, well, this is great, but it's not replicable. So what BPC has been working on in the past few months is, or actually past few years, has been looking at these models and trying to figure out, well, there are a lot of researchers trying to figure out why they're not replicable or how to spread and scale them. And one of the 6 things that is typically listed as a problem for spread and scale is the barrier of federal law and regulation. So what we have been doing is looking at these programs and trying to identify what the barriers are in Medicare Advantage, what the barriers are in special needs plans, in patient-centered medical homes, in traditional fee-for-service. We've been working on financing long-term services and supports, which is so closely related to care for patients with multiple chronic conditions. It's really just a continuum. And then finally, we will be turning, and we've been working on quality and access in rural areas because there are many areas of the country that don't have access to the types of services that we would like to see made available. And then finally, our next project coming up in April will be beginning on a project to integrate primary care and behavioral health services. So just as an example of why this is so important, I don't think this is a problem in California. I know that they've been a part of the Financial Alignment Initiative, have a number of special needs plans for dual eligible individuals. But believe it or not, in some states, there are dual eligible beneficiaries, Medicare, Medicaid beneficiaries, who are enrolled in 4 private managed care plans. One for their clinical health services, one for behavioral health, one for dental, and one for long-term services and supports. Now, as someone who has worked in this area for a long time, and I'm trying to help my mom navigate the system now, can you imagine what it would be like to have to figure out when a claim is denied or when you're not getting something that you need, which of these 4 health plans do you call to figure out how to remedy the problem? It's really not happening. And so one of the recommendations that we have made has been to better integrate these systems. So I won't go into the details of these proposals. We have a number of these reports online. The most recent in January of 2017, which is the policy roadmap, a policy roadmap for caring for patients with complex needs. But many of the recommendations are things that not only we're putting forth, but we're seeing a lot of other organizations doing the same thing. We're all coming to the same conclusions. So I can't stop without highlighting the fact that something good did happen this year. Now, I think it still remains to be seen what the effect will be, but a bipartisan group of senators came together and put together the Chronic Care Act. and looked for solutions to improve care for patients with multiple chronic conditions. And what was in that legislation, it was included in the Bipartisan Budget Act, was permanent authorization of Medicare Advantage special needs plans, requirements for better integration of services by these plans, so you don't have these 4 different health plans that are out there, greater regulatory authority for the Medicare-Medicaid Coordination Office, and that is the office in Washington, D.C. that within CMS, it's charged with coordinating Medicare services and Medicaid services for those who are duly eligible for Medicare and Medicaid. The challenge has been that they have not given them really any regulatory authority at all. And so what is happening is when they try to make a change, they are always overruled to a certain degree by the Medicare office at CMS. And I had a personal experience in this. I was working on one of the 3-way contracts for the Financial Alignment Initiative when I was at GW, and a colleague and I were looking through that contract language, and we said, look, this doesn't work for Medicaid. We need to figure out how to fix this. And the response was, we have a certain number of weeks to get this done. We're going with Medicare Advantage. And we wonder why some of these demonstrations don't always work the way we expect them. But one thing that I think is really critical that happened is if you are in a Medicare Advantage plan, if you are a Medicare Advantage plan or a provider, and you would like to target services to someone with multiple chronic conditions, you were not able to do that because if you offered a supplemental benefit to one Medicare beneficiary, you have to offer it to everyone. And when I'm talking about supplemental benefits, it could be something like home-delivered meals. It could be minor home modifications. It could be non-emergency medical transportation. These types of things that are the types of not exactly social services, but I would call them bridge services to help people stay in their homes. And under the law, you could not do that in Medicare Advantage. So this has been changed now. One of the things that we really need to watch is when it's implemented. How does this really play out? Is there a commitment at CMS to give plans and healthcare providers the flexibility they really need to provide these services? The statute says that they can cover anything that's reasonably expected to improve or maintain health and functional status. And so could that be a dog walker for grandma on a really icy day when she's at risk for serious falls? Potentially. But what you would do is leave that up under this idea is you would leave that up to the patient's care plan. You would, the providers and the individuals who sit down together to develop a plan based on what an individual needs rather than what's covered under Medicare and Medicaid. So that is the real vision here. And I like to say that there are baby steps. The second thing that we really need to worry about is whether or not the Medicare Advantage plans will take advantage of this. I know that some of the special needs plans that have been working with Medicare and Medicaid for quite a while have been doing this for a long time. And then finally, just a few next steps that we are continuing to work on that we're, Congress will, we hope, persevere. They are beginning to look at other things that they can do on a bipartisan basis, at least at the staff level, and try to bring it to the leader level. So that's it. And one thing that, if I could just add one last thing is, we look at all these things and we really worry about whether or not they're actually going to control costs. And I don't know if you've been reading the papers lately, but there has been this discussion now about advances in science that might let you cryogenically freeze someone and then reanimate them later. Well, believe it or not, in the 1980s, when they were negotiating a budget deal with the first President Bush and members of Congress, they were so frustrated about how they were actually going to save costs in the short term. And so one staffer came up with this idea and presented it to staff, not the leaders, that when a person turns 75, they are put in cryogenic freeze for 20 years. And then they're awakened at 20 years later, and thus there were no Medicare or Social Security expenditures. And so I know that we will never go that far, but it's been considered.
We can all go home now. Well, I was actually surprised you didn't say one thing, and that is the problem here is fee-for-service medicine. Do you agree that that's the problem, and that whether it's Medicare Advantage or ACOs or other forms of new health plans, that they're all designed to get us away from fee-for-service?
I think that is true. One of the challenges, though, is how do we get alternative payment models and these other systems of care more widespread? I think, what percentage of, somebody told me it was like 20% of the country lives in an area where there's a Medicare Advantage plan. And so we need to figure out, I know they've tried for years to get Medicare Advantage plans into rural areas, and it hasn't been particularly successful. So what we need to do is figure out some sort of provider-driven organization that has an incentive. It doesn't have to be an organization, it can be a physician, that has an incentive to treat people and keep them well and provide these services and provide patient-centered care. So you're absolutely right, but I don't have the answer.